Hi, adverse. Um, we are taking just a minute so that we will get to know whether the audio visual is fine or not. I'm just getting the stream over here. Hello, everyone. Very good evening. Am I audible and visible to you guys? Please let me know if I'm audible and visible to you guys. Refresh my screen. Hello. So today we are going to discuss about hypoxia because this is the topic where I'm getting lots and lots of doubts and questions and what is content, what is saturation, and what is you can say content in the arterial side, venous side, when it is going to increase, when it is going to decrease, what do you mean by cyanosis, is it different than the cyan methemoglobin, the reduced hemoglobin, what is it and how much percentage it is required. So we are going to deal with all those things today. All right, so today's today's class is specifically given for the hypoxia, and I'm sure that I'll try to solve all the doubts that you're having regarding it. So first thing first, let's start with the nice quote, that is, the biggest risk is not taking one, dare to leap into the unknown. Right, so let's see what the hypoxia says to us. Okay, hi adverse. So let's start with the hypoxia. I hope everybody is there. Good evening, Osama. So what do you mean by hypoxia? See, there are two terminologies. One is hypoxia, one is hypoxemia. I always told you that whenever there is a word emia comes, what do you mean by emia? Can anybody tell me what do you mean by emia? Yes, please. Emia literally means blood. So you take uremia, hypernatremia, hyponatremia, hyperkalemia, then natremia, calcemia. Everything is related to anemia, polycythemia, leukemia. Everything is going to be related to blood. All right, but over here we are talking about hypoxia. Hypoxia mein there is no emia terminology which is given. So please remember, this is related to decrease in the oxygen supply to the tissue or at tissue level. Right? EMEA, if it comes, very good, Osama. Hi, Om. So if EMEA comes, that means I'm going to write it as hypoxemia. Hypoxemia, if I write, there is a emia word is coming. That means you know that this is going to be decrease in the oxygen at or in the blood. We can say at the blood level or in the blood. Right? But we don't usually talk in terms of hypoxemia. We usually talk in terms of hypoxia, right? Because definitely we have to supply the oxygen towards the tissue, isn't it? So hypoxia is decrease oxygen supply or decrease oxygen in the tissues. That's all. This is the simple terminology of it. All right, so let's see what can be the causes. First of all, let's see the overview. I'm going to draw few things over here. So let's draw it from the first. Let's say this is the alveoli which is present or inside the lung. So it is present in your lung, and this is the atmospheric air which is going into the alveoli, isn't it? Now 21%, let's say we are at sea level, right? So how much is the atmospheric pressure? It is going to be 760, of course, mmHg, right? So it is going to be 760 mmHg. Now, if I have to calculate the pressure of the oxygen, how can I calculate? I'm going to apply the Dalton's law and I'm going to do the 21%. I know that the overall, if we take all the gases, 21%, around 21% is going to be my oxygen. So it will be 160 mmHg, isn't it? 160 mmHg. All right. So this much is the oxygen which is going to be present at sea level. All right. We are not considering the pollution and everything over here. All right. Hi Dhruba. Hi Bilal. So good evening. Now let's say if water vapor pressure I add up and some, you can say I subtract some of the things, then FiO2 I'm going to take it as 160. But as soon as it is going to come towards the alveoli at the end of it, we are going to say that it is only going to be 104 mmHg. All right, but around 100 mmHg is going to be the oxygen which is going to be there. That is nothing but the partial pressure of oxygen which is going to be there. Now what happens to that partial pressure of oxygen? Of course, in the lungs, we are not just having the alveoli, but we have the pulmonary artery, pulmonary vein, and in between, we are going to have the pulmonary capillaries. What is going to happen? See, as soon as I'm going to have the oxygen over here, in the pulmonary artery, let's say pulmonary artery is the artery which is going to carry the deoxygenated blood, right? And this is the only exception in the non-pregnant female. In the pregnant female, we do have umbilical artery also, which is going from the placenta towards the you can say from the fetus towards the placenta. All right, so in that, we actually, in the human life per se, we do have only two arteries which are going to carry the deoxygenated blood. One is the pulmonary artery, second is the umbilical artery. We are just concerned about the pulmonary artery over here. I know that the partial pressure of oxygen is going to be 40 mmHg. Now what will happen? Of course, we all know the law of diffusion. It is going to go from the high concentration towards low concentration, right? So as soon as the pulmonary blood is going to come near the alveoli, of course, there will be diffusion of gases which is going to take place, isn't it? So I'm writing it over here that there will be diffusion of gas. Which gas we are talking about? We are just concerned about the oxygen right now. Yes, the carbon dioxide is also going to go out. We are not going to talk about it right now. All right. Then what will happen? Where this maximum oxygen goes, can you tell me who is the carrier of oxygen? The oxygen loves to get transported with the help of RBCs, right? So they're going to travel through the RBC. In the RBC, I'm going to have hemoglobin, right? So hemoglobin bound form is going to be 98 to 99%. So it is going to go via that. But one more thing that you have to note, that first thing first, the maximum transport of oxygen is going to take place with the help of hemoglobin. That is how much percent? 98 to 99%. Understand? But there is another form which is going to be very important, that is dissolved form. In the dissolved form, I agree that only 1 to 2% of the oxygen will be transported, but according to Henry's law, it says that the partial pressure of any gas is dependent upon dissolved form. So this form is very, very important. Why? Because when I'm going to write the PaO2, the small a is always for arteries. So when I'm going to write PaO2, I just write PO2, right? When I'm going to write either PaO2 or PO2, that means partial pressure of oxygen or partial pressure of oxygen in the arterial side. All right. So please remember, whenever I'm going to write small a, that denotes in the arterial side what is happening. And when I'm going to denote V, that means on the venous side what is happening. All right. So we are going to talk about the content and the saturation and everything. First of all, just understand P means partial pressure over here. And it depends on that little amount of blood which is going to get the dissolved form, or which is in the form of dissolved format in the artery or the vein. All right. So one thing is clear, that dissolved form, though it is very, very less in comparison to the hemoglobin bound form, but it is very important because the partial pressure is going to be dependent on it. Now, what will happen the next? The next is, find the hemoglobin got all the, you can say oxygen, right? 98 to 99%, and some oxygen got dissolved. Where it is going to go? Of course, it is going to go towards the blood. Let's say this is left atrium, left ventricle, right? Of course, it is going to have the aorta, and through the aorta, what is going to happen? Through the aorta, it is going to carry the blood towards the tissue, isn't it? It is going to carry the blood towards the tissue. Now, what will happen in the tissues? That the tissues are going to be there, and of course, they are doing the metabolism. So now what will happen? Because of the metabolism, they have the lesser amount of oxygen. How much again? 40 mmHg, isn't it? I'm not writing the mmHg because it is taking a lot of space. So you just understand, or rather write it like this. Okay. Now what will happen, that the capillary will start and then the venous side will start from here. All right. Now let's understand. First thing first, what will happen to the oxygen into the tissues? Why they require? Ultimately, we have to do the metabolism. Everything boils down to only one thing, that you have to do different functions. Your tissues has to do different functions. So they are going to do what thing? Metabolism. What the metabolism is going to do? Whatever you are eating, glucose, right, or let's say carbohydrate, fat, proteins, that will be boiled down into the energy, that is ATP, right? I require ATP to survive. All right. And who is going to give me the maximum amount of ATP? Of course, the aerobic metabolism. So let's say this is the mitochondria, and what the mitochondria contains? Mitochondria contains cytochrome oxidase and different enzyme. Main one is cytochrome oxidase. And which cytochrome oxidase is main one? That is going to be our cytochrome P450. That is the main one. All right. So this is, let's say, mitochondria, which is going to utilize the energy with the help of cytochrome oxidase. Or we can write it as cytochrome P450, which is going to be the main one, which is going to utilize the oxygen and convert the glucose into the ATP. Let's assume that. Okay. So this is going to be the oxygen journey, which is going to be there in our body. Now let's do lesion at one site. Okay. Let's say the person goes to the high altitude. What is going to happen if he goes to the high altitude? Then this sea level pressure is going to decrease. So if overall pressure, I'm not saying the oxygen concentration will remain 21%, but the overall pressure, atmospheric pressure or barometric pressure, is going to decrease. So if I calculate, let's say I said that it is going to be 500 mmHg, the atmospheric pressure. So the 21% of 500 is definitely going to be lower. 21% of 400 is definitely going to be lower than 160 mmHg. That means as the person is going to go on the high altitude, what is going to happen? As the person is going to go on the high altitude, the first thing that is going to occur is the atmospheric pressure is going to decrease, not the concentration of the oxygen. Atmospheric pressure decreases, and according to the Dalton's law, I know that the overall content of the oxygen in the atmosphere is going to decrease. So now I'm going to have a lesser concentration gradient of the oxygen towards the alveoli. So of course, in the atmosphere itself, the oxygen is very less. So whenever I'm going to breathe, lesser oxygen is going to come in my lung. And definitely, if lesser oxygen is coming in my lung, lesser oxygen will go in the arteries and finally towards the tissue, and the tissue will suffer from the hypoxia. So the first thing, I'm just going to code it with the color. First thing, let's say that there is a decrease in the atmospheric pressure, or let's say there is another problem. What is the problem? The problem is the person had the fibrostic lungs, right? Or fibrosis. What will happen? There will be issue in the diffusion. Or let's say the person is having the problem in the heart, but that is not having the problem in the heart per se, in the circulation, right? That means the heart is fine, its contractility is fine. The thing is, it is having the hole in between. In the, let's say, we have to draw the right side of heart also for that. Let's say this is the heart. I'll draw it over here. A simple heart, right? If the person is having left towards the left shirt, that means from the right towards the left. Now what is happening? See over here, the blood is getting mixed. This is the left side of heart, this is the right side of heart. So deoxygenated blood is getting mixed in the oxygenated blood. So because of that, what will happen? The deoxygenated blood is going to go towards my tissue. And definitely it is the mixed amount of you can say mixed blood is going, so the oxygen is not going to be 100 mmHg there or 98 or 95. It is going to be much lesser. If lesser amount of partial pressure is present in my blood, of course again the concentration gradient, let's say it is 80 mmHg, now only 40 mmHg concentration gradient is going to be there, which is going to be left in the you can say towards the tissue with the mixed blood. All right, so concentration gradient is going to fall. So because of these three reasons, if the problem is there towards the tissue, that means the tissue is suffering from the hypoxia because of either the atmospheric pressure is lower or diffusional disorder is there. That means anything, fibrosis, hyaline membrane disease, anything, right? Or there is a problem in the heart that the person is having right to left shunt. What will happen because of all of this? Because of this, ultimately the tissue will suffer from hypoxia. That's why we are going to call that as hypoxic hypoxia. Hypoxic hypoxia. All right, if this is the problem. Now let's move on to the next type. Let's say the atmosphere was fine, the alveoli of the person was fine, his heart was absolutely fine. The problem is, let's say now a female patient came, right? And in India, we know that most of the population is what thing? Is vegetarian, right? And let's say the hemoglobin itself is very less. Now what will happen? The carrier is lesser, right? So what will happen to overall content of the oxygen in the blood? It is going to be lesser, right? I'm saying content, not saturation. Understand? Overall number of hemoglobin per 100 ml, I'm having lesser content of oxygen. All right, so lesser oxygen will go towards the tissue, but tissue has the same demand. So what it is going to do? It is going to extract as much as oxygen possible. All right, so what will happen? We'll see that there is something known as saturation, which is going to differ in the venous side. All right, so second thing is there are less ships available to carry the oxygen. Then this type of hypoxia will be called as anemic hypoxia. Second is anemic, first was hypoxic. Now, let's say that now the oxygen is fine, atmospheric pressure is fine, alveoli is fine, and also the hemoglobin is fine. Now, let's do the problem in the heart. Heart problem we have done already, not that one. The problem itself in the heart, contractility, which will not able to give the proper cardiac output, or it will hamper the circulation velocity or speed. So now what will happen? If we hamper the circulation speed or velocity, definitely again the tissue will suffer from hypoxia. Now what will happen? See over here. I want your full attention, otherwise you won't understand. Let's say there is a problem in the circulation. If there is a problem in the circulation, we are going to call that as stagnant hypoxia. Why we are going to call that as stagnant hypoxia? Let's see. First thing first, let's say the blood is coming over here, but my heart is not able to pump. See, heart do contraction and relaxation, but now the heart is having arrhythmia like condition, or the heart lost its contractility because of the congestive heart failure. Now what will happen? It is not able to pump the blood properly. So if it is not able to pump the blood properly, the velocity of the blood or the circulation speed is going to decrease. And because of that, the blood will stay at one point for longer duration. But tissue doesn't know all this story, na? It requires the oxygen, it will take the oxygen. So from where it is going to take the oxygen? It is going to take the oxygen from whatever available source. That means the rest of the RBCs, which should move forward with very high speed, that will not move forward. So the blood will stay there for longer time, but tissue is extracting more and more oxygen from the same hemoglobin, unless and until it is getting emptied, right? So what is going to happen? If I ask you what is going to happen to the content of oxygen on the venous side, which we call it as CVO2, and content of oxygen on the arterial side, we are going to call it as CaO2. Because of the slow blood flow, the RBCs are going to take more time to cross the tissue. So they are going to stay there for a longer time. The tissue gets more interaction with that particular RBC, and more the interaction, it is going to extract the oxygen more and more from that particular RBC. So now what will happen? Even though if I say that over here it is, let's say 100 mmHg, 100 to hota nahi hai, let's say 95 to 98 mmHg of partial pressure of oxygen is going to be there, and the CvO2 usually have 40 mmHg, but it is going to decrease. The partial pressure won't decrease, the CvO2. If I ask you how much is the CaO2, this is partial pressure of oxygen. If I ask you CaO2, how much it is usually 19 ml per deciliter. That means per 100 gram of RBC, I'm going to have 19 ml of content of oxygen. And normally it is going to be, let's say 14 ml per deciliter. If I write 14 ml or 14 ml percentage, 14 ml per 100 ml, it's the same thing. Deciliter bolo, percentage bolo, 100 ml bolo. It's the same thing. All right. But now because of the stagnant flow, what will happen? As soon as there is a stagnant hypoxia or the circulation is slower, the arterial side content is going to be normal, but the problem is going to be, the problem is going to be there on the venous side. So 19 is going to be fine, but as soon as it comes on the venous side, it is going to be either 12, 10, 8, depending on how much is the you can say velocity which has been decreased. All right. So please understand that. Now, if I say the heart was also perfectly fine, first thing we talked about, if the atmosphere is not good or the alveoli is not okay, right? But let's say these are fine. The hemoglobin content is also normal. Let's say the third one, the heart, which is also normal, right? Then the problem is there in that cytochrome oxidase. Now what will happen? See over here, if the problem is there in the cytochrome oxidase, what will happen in this condition? The tissue will not be able to utilize the oxygen. The problem will be there in the utilization, right? So final step is usually utilization, which will be hampered. If the tissue is not able to utilize the oxygen, ultimately what will happen? There will be abolition of the gradient. That means the tissue oxygen is also going to reach to 100 or 95, 98. And if both are 95, 98, then the oxygen will not come towards the tissue. Now, whatever new blood is coming after giving the oxygen, whatever new blood, let's say there is a supply, new blood has been coming over here. Whatever oxygen was there on the arterial side, it will not go towards the tissue because there is abolition of the gradient over here, because the utilization is not occurring, tissue is not utilizing the oxygen. Whatever previous oxygen was there, it is still there in the tissue, right? So what will happen to that oxygen which came right now? It will move on towards the venous side. So what will happen to the CvO2 over here? It is going to be equal, it is going to be almost equal to CaO2. The difference between the content from the arterial side and the venous side, it is going to decrease. So CaO2 minus CvO2, which should be 5 ml per deciliter normally, that will reduce in the stagnant, which will decrease in the type of hypoxia, which we are going to call it as histotoxic hypoxia. This is histotoxic hypoxia. Why we call it as histotoxic? Because there are some toxins or let's say poisons which are going to affect these cytochrome oxidases or cytochrome P450 or any other, you can say the enzymes which are going to affect the oxygen utilization. So the toxicity is there in the tissues, so they are not able to utilize the oxygen. Usually we do have toxicities in our departments also. That's why we are not able to give our best, mental efficiency is going to be reduced. So that happens, right? Unnecessary, notifications and unnecessary things are going to go on. Same is going to happen with the tissue over here. All right. So 4 types of hypoxia we have discussed. What was the first? Hypoxic, right? The second is anemic, wherein in the hypoxic, either there is a problem in the atmospheric content, we can say not the problem, but it has been reduced, as such happens in the high altitude, right? Then or there is a problem in the diffusion, that is either the person is suffering from diffusional disorder, or there is a problem in the alveoli per se, or there is a right to left shunt in which the blood is getting mixed. the blood is getting mixed on the arterial side, and the mixed blood is going to go towards the tissues, right? So these three things are going to come under hypoxic. The hemoglobin content is lower, it is going to come under anemic, right? If the blood flow is slow, then it is going to be called as stagnant. And if the tissue is not able to utilize, then it will be called as histotoxic. So there are 4 types of hypoxia that we have discussed. So let's move on to one more thing, then we will move forward, or we will come back over here. Most common type of hypoxia is hypoxic hypoxia. We'll come back to that later on. So see over here in this chart, I have I tried to give the gist of what we are going to talk, right? So the first is atmospheric air, right? So FiO2 into barometric pressure. The FiO2 is going to remain the same, the fraction of inspired oxygen. All right. So fraction into the barometric pressure, the barometric pressure is going to decrease. So overall partial pressure is going to decrease. Now, please understand, this is the only type of hypoxia in which partial pressure of oxygen is going to decrease. That is hypoxic hypoxia. If in the hypoxic hypoxia, partial pressure is decreasing, what will happen? What will happen to the dissolved form? The dissolved form is going to decrease, and that's why the partial pressure is decreasing, isn't it? That means the dissolved form is going to decrease. So this is the only type of hypoxia which is going to have the decreased amount of dissolved oxygen. Please remember that. And this is very, very important when we are going to talk about the chemoreceptor stimulation. This is the very important thing. All right. Now, let's say the barometric pressure has been decreased, or there is a problem in the lung, or we can add on one more thing, that is right to left shunt in the heart, right? So all that is going to come under hypoxic hypoxia. Second, if the hemoglobin is not normal or it has been reduced, that will be called as anemic hypoxia. If the problem is there in the either cardiac output, that is in the heart, or let's say there is a problem in the blood vessel. What can be the problem? Let's say there is a condition which is known as shock, right? Hemorrhagic shock, or you can say the warm shock, which is a distributive shock, in which what is going to happen? Either the vessels are going to get dilated, or there will be, in the hemorrhagic shock, what will happen? The person will lose a lot of blood. Of course, he's going to lose a lot of oxygen carrying capacity also, that is with the help of hemoglobin or RBCs overall, right? So in that, we are going to call it as the problem in the circulation is there, and that's why we call it as circulatory hypoxia or stagnant hypoxia. If the muscles or the mitochondria per se of any tissue, it is not able to utilize the oxygen, then that will be called as histotoxic hypoxia. All right. So let's move on forward. One by one, we are going to go step by step. All right. First step, we know what do you mean by partial pressure of oxygen. We know that, right? What is partial pressure of oxygen? That is PO2. If I have to denote that specifically on the arterial side, I'm going to write PaO2. That is on the arterial side. And I told you that it depends on the dissolved form. And dissolved form is usually very, very less. It is going to decrease only in the case of hypoxic hypoxia, because overall content from the atmosphere itself has been reduced, right? And that's why what will happen, the gradient from the atmosphere towards the alveoli will be reduced, and the gradient is also going to be reduced from the you can say alveoli towards the tissues, right, or towards the pulmonary capillary. And that's why the lesser will be the dissolved form. Why? Because overall lesser oxygen is present in the, you can say, alveoli, or it is coming lesser in the pulmonary capillaries. Then only it is possible. So please understand, the partial pressure is only and only going to decrease in the case of hypoxic hypoxia. In the rest of the condition, it is going to be normal. All right. Let's move on to the hemoglobin bound oxygen. First thing first, if I say there is a lesser oxygen available, of course, lesser oxygen will bind to the hemoglobin, and whatever oxygen is going to bind to the hemoglobin, I'm going to call it as oxygenated hemoglobin, right? Or a hemoglobin bound oxygen. One and the same thing, right? Of course, if it is lesser oxygen coming towards the pulmonary capillary, lesser will be the hemoglobin bound oxygen, lesser will be the CaO2, and lesser will be the CvO2. Everything is going to be lesser in case of hypoxic hypoxia, right? Why? Because the problem is there in the, you can say, the root cause, that is going to be atmosphere or in the alveoli, all right, which is actually providing us the oxygen. So of course the oxygenated hemoglobin or the hemoglobin bound oxygen is going to be lesser. What will happen to CaO2? Of course the content is going to be decreased because lesser oxygen is coming in the pulmonary capillary, so that is also going to decrease. So this is known as content. And when we are going to talk about content, I'm going to talk in terms of per 100 ml, how much oxygen is present, right? Oxygen present per 100 ml, that is the, I'll write like this, content means oxygen availability per 100 ml, right? So that is known as content. A likha hai to it is going to be arterial. If it is written as V, V means venous side. All right. Then coming to the AV oxygen difference, how we are going to calculate? CO2, you know, CVO2 also, you know, minus that, right? That means we have to subtract the CVO2 from CaO2. Kar lo, kya aega? If both the things are decreasing, see, CaO2 is also decreasing, CVO2 is also decreasing. But the difference is going to be only 5 ml per deciliter. Why? Because that is the demand of my tissues in the resting condition. So this is going to be normal. Because both are decreasing, so value is going to be same. All right. And there is something known as cyanosis. What is cyanosis? Bluish discoloration of skin and mucous membrane. Why the skin and mucous membrane turns blue? Because there is something known as deoxyhemoglobin, or it is also known as reduced hemoglobin. If it is more than or equal to 5 gram%, that is going to give the bluish discoloration. Why? Because hemoglobin is the pigment which is actually decide the color of your blood. If it is bound to the oxygen, it is going to give that red color, pinkish red color, right? Nice red color. But if it is not bound to the, you can say oxygen, it is going to give the different colors. We will see that, all right? But remember, if the overall blood, I'm saying the pulmonary capillary blood, it is having more than 5 gram% of the deoxyhemoglobin, then definitely it is going to give the, what thing? Blue discoloration or bluish discoloration. All right. Usually it is around 2.4 gram%. Why? Because I'm going to see new blood is coming, right? And the old blood is going. So usually the capillary is going to have the mixed arterial and venous blood over there, right? I cannot just take the venous side. Okay, so please remember, when we say that 5 gram%, that means per 100 ml, I require 5 gram% of deoxyhemoglobin, which is not going to be present at any moment in the normal healthy person, which will be only available if there are hypoxias, such as hypoxic hypoxia and stagnant hypoxia. For now, just remember, obviously the oxygen level has been reduced, so hemoglobin bound oxygen has been reduced, and that is why the cyanosis is happening. Why? Because the hemoglobin is present, but the oxygen is not present, and that's why whatever hemoglobin is present, that is without the oxygen, and in that sadness it turns blue, right? So please remember, what are the causes? Causes are high altitude, fibrosis, diffusional disorders, neuromuscular disorder. NM disorder means neuromuscular disorder, such as myasthenia gravis, kyphosis, scoliosis. In that, what happens is the lungs are usually restricted. There is no parenchymal disease. What do you mean by parenchyma? Parenchyma means whatever organ is made up of, such as elastin tissues, connective tissues, all these things, right? So lung, alveoli, they're absolutely fine. The problem is, let's say the person is having kyphosis or scoliosis, or let's say he's having myasthenia gravis disease. What will happen? His nerves and muscles, they're not able to put a proper amount of force. They're not able to generate a proper amount of force, and because of which what is happening is the person is not able to respire properly. So if he's not able to do inspiration properly, of course lesser amount of air will come, lesser amount of oxygen will come, and because of that what will happen? Definitely the person will land up into hypoxic hypoxia. All right, so that can be one of the reason, or there can be right to left shunt. In that the blood is going to get mixed, right? So not the arterial, but mixed blood is going to go towards my tissue. All right, coming on to the anemic hypoxia, we know that the partial pressure is fine. Problem is in the hemoglobin level. So what do you mean by anemia, by the way? anemia में you have to write a proper definition. Decreased oxygen carrying capacity of blood, again I'm repeating, decrease oxygen carrying capacity of blood either because of decrease in the hemoglobin level or because of decrease in the RBC or because of both, right? So that is the complete definition of anemia. Over here we are talking in terms of hemoglobin, right? So hemoglobin has been reduced, right? That is known as anemia. Now understand, hemoglobin itself has been reduced. So understand the deoxyhemoglobin or reduced hemoglobin cannot be higher more than 5 gram %. So will the patient be able to show us the cyanosis wala symptom or sign? No. The cyanosis is going to be absent over here. You cannot see the cyanosis. Why? Because overall hemoglobin levels are low, so you cannot have more reduced hemoglobin. Of course, that is a logical thing. All right. Now, what will happen to the partial pressure of oxygen? It is absolutely fine. There is no problem in the partial pressure or dissolved oxygen. There is a problem in the hemoglobin itself. Hemoglobin is less, so of course, hemoglobin bound oxygen, or we can say the oxygenated hemoglobin, is going to be lower, right? So that is lower. CaO2 is going to be lower and CvO2 is also going to be lower. But since the tissue extraction speed is same, so what is going to happen? Definitely the AV difference is going to be normal. It is going to be 5 gram % only. All right. Now coming to the stagnant hypoxia. What is the problem in the stagnant? The name itself telling you it has stopped moving or it is moving at a very, very slower speed. What will happen in the stagnant? Atmospheric level of oxygen is fine. Alveolar level is fine. Hemoglobin is also fine. So what will happen to the partial pressure? It is going to be normal. Hemoglobin bound oxygen, since there is no problem in the stagnant hypoxia, there is no problem in the hemoglobin, it's absolutely fine. So that is going to be normal. And if the hemoglobin is normal, definitely they are the ones which are going to carry maximum amount of oxygen. So CaO2 is going to be normal. But understand, slow blood flow is there, sluggish blood flow is there. What will happen? The hemoglobin will stay there for longer time. If it is staying there for longer time, what will happen? Definitely, the tissue will extract more and more and more and more oxygen. And because of that, the CvO2 is going to decrease, right? The CvO2 is going to decrease. If the CvO2 decreases, CO2 is normal. And let's say CvO2 should be this much, but the CvO2 has been reduced. So what will happen to the difference? The difference is going to increase because only the CvO2 has been reduced. All right. So what will happen? The difference is going to increase because the CvO2 has been reduced. So CvO2 will be reduced, and because of that, the difference between CaO2 and CvO2 is going to increase. Let's come on to the histotoxic hypoxia. Histotoxic hypoxia mein everything is going to be fine. What is the problem? The problem is the tissue itself. Tissue is not extracting the oxygen. So what will happen to the CvO2? CvO2 eventually is going to rise. So what will happen to the difference? The difference is going to be vanished or it will abolish after some time. Why? Because the tissue is not utilizing the oxygen. So normally it should be 5 gram %. The difference, AB difference should be 5 gram %. But eventually what will happen? The CvO2 will increase. If the CaO2 is normal, CvO2 is increasing, the difference is going to be nullified after some time. So difference is going to decrease, right? Now, if I ask you in the stagnant, will you be able to see more than 5 gram % deoxygenated hemoglobin? Yes, because the tissue is extracting more and more blood or more and more oxygen. What will happen on the venous side? I can see the deoxygenated hemoglobin, which is going to be much, much more than the 5 gram %, and the cyanosis is going to be seen, right? What are the causes of anemic hypoxia? It is anemia itself. Methemoglobinemia, that means the Fe2 plus is going to be converted into Fe3 plus. The iron form is going to be changed from the ferrous to ferric, right? And as soon as it becomes ferric, it will be called as methemoglobin. So methemoglobinemia, that is going to be the cause, and carbon monoxide poisoning also. Now understand, the carbon monoxide poisoning itself will give the cherry red color, right? And that's why the PaO2 will give the patient's PaO2, if you check, it is going to be absolutely normal even if the severe CO poisoning is there. All right. Now, what are the causes of stagnant hypoxia? Hemorrhage, CHF, and shock. That is congestive heart failure. This is hemorrhage. All right. Now, what about histotoxic? Cyanide poisoning, beriberi, that is vitamin B deficiency, or sulfide poisoning. All these are causes of the histotoxic hypoxia, which are going to hamper the enzymes, right, which can utilize the oxygen and make the ATPs. They are hampered, so histotoxic, right? The tissue is suffering from the toxicity. If I'm not utilizing the oxygen in my tissues, of course, more oxygenated hemoglobin is present even on the venous side. Will I be seeing the reduced hemoglobin? No, of course, the reduced hemoglobin will be almost zero, right? So that is going to be, the cyanosis will be absent over here. It will not be seen. So this is the chart that you have to remember, okay? So first thing first, whenever you are reading about the hypoxia, what you need to do is, first thing, understand what you mean by partial pressure of oxygen. That is the dissolved form of oxygen. Second, understand what you mean by CaO2. That is content of oxygen. What do you mean by SaO2? That is saturation of oxygen. When I talk in terms of saturation of oxygen, I talk in terms of one single hemoglobin. I'm not going to take 100 ml of blood into the account. I'm going to just talk in terms of one single hemoglobin. Okay, so that is the difference between content and the saturation. All right. Now, if we talked about it, let's understand what is going to happen in the most common hypoxia, that is going to be hypoxic hypoxia. How the body deals with this. If the person is suffering from hypoxic hypoxia, what will happen? Hypoxia, that means this is one of the decreased PaO2 is going to be there, right? And because of that, the peripheral chemoreceptors will be stimulated, right? We know glomus type 1 cells. So peripheral chemoreceptors are going to be stimulated. If peripheral chemoreceptors are stimulated, what will happen? Of course, their one job is that they increase the ventilation. So what will happen? Hyperventilation can be seen. So they will stimulate the ventilation, and that's why what will happen? There will be increase in the ventilation, which is known as hyperventilation, which will be seen because of the stimulation of this chemoreceptors. As soon as they start to do hyperventilation, what will happen? More air will come inside, and that means more oxygen will come inside the, you can say, alveoli. But with that, the person is doing more expiration also, na? So what will happen to the carbon dioxide level? The carbon dioxide is more diffusible, 20 times more diffusible as compared to the oxygen. So more carbon dioxide is going to leave the lung. And because of that, what will happen? If more carbon dioxide is leaving the lung, that will lead to carbon dioxide washout. Very, very important term. And carbon dioxide is the main stimulus for what thing? Carbon dioxide is the main stimulus for the respiration, right? If that is washing out, what it will do? It will go and inhibit the peripheral chemoreceptor. Why? Because the carbon dioxide is the main stimulus, right? Main stimulus is lesser, and that is known as apneic point. There is something known as apneic point. The carbon dioxide levels cannot be zero because it's a main stimulus, right? We require some amount of carbon dioxide. Just for now, remember, we require at least 37 mmHg. In the normal healthy person, we require 37 mmHg if the pH is normal, right? So that is known as apneic point, below which, as soon as the let's say carbon dioxide levels comes to 37 mmHg, the respiration will stop. Why? Because it is going to go and inhibit the chemoreceptor, right? And this effect is known as braking effect. This effect is known as braking effect, right? It is breaking that rhythm of hyperventilation, okay? Not only that, whenever the carbon dioxide washout is going to happen, there are another compensatory mechanism which will be activated. What are those? First thing first, the kidney comes to help. What the kidney is going to do? Kidney, of course, the carbon dioxide is washing out, and because of that, what will happen? Let's write over here, alkalosis. Alkalosis is taking place, and because of that alkalosis, the kidney comes to an aid. What the kidney will do? Of course, the alkaline environment is much more. So what the kidney should do? It will increase the bicarbonate excretion. and it will increase the H plus retention. That means I can also write it will decrease the H plus secretion from the tubules, renal tubules, into the, you can say, in the urine per se, right? So from the cells or from the blood into the tubule. So secretion is going to be decreased, right? Not only that, the 2,3-DPG, the 2,3-DPG or BPG is going to be reduced, which will ultimately will cause what thing? Sorry, it is going to be alkalosis. Now it is going to be increased. So 2,3-BPG is going to be increased, which will lead to the increased release of oxygen from the hemoglobin towards the tissue. All right. So the tissue is suffering from hypoxia. How the you can say 2,3-DPG is helping? It will cause more release. So this is known as Bohr's effect. How to remember? Bohr's effect. I'm deliberately writing is as Bohr's, R capital. What is going to do? It is going to cause the release, which will actually help us out in the condition of hypoxia. It is going to help us to compensate the hypoxic effect. All right, which is the right shift, which is going to occur, and that will provide more oxygen to the tissue. Okay. So provide more oxygen to the tissues. So please remember. Now, because of increase in the retention of this H plus ion, what will happen? One more thing, that the CSF is going to have a little bit more acidic environment, which will start eventually. Of course, the H plus will not cross, but the CO2 also start to accumulate there, and that is going to lead to increase in the pH eventually of the CSF. That can stimulate the central chemoreceptors. So it depends on how much is the pH, how much is the H plus ion retention, whether it is affecting the CSF or not. And depending on that, the peripheral chemoreceptors will have the balance of respiration. All right. So it is the mechanism with which the hypoxia can get compensated via the body. The last thing that we are going to talk about is the content versus saturation. I just now told you that content means I'm going to talk in terms of per 100 ml. Oxygen per 100 ml of blood. Per 100 ml of blood. And when I'm talking about the saturation, that means I'm going to take the oxygen binding to the hemoglobin. That means HbO2. That means I'm going to take how much oxygen is there if I take one single hemoglobin. Okay, just understand, one single hemoglobin, that means the saturation. If I'm talking about content, means overall 100 ml of blood I'm taking, whether that be dissolved or that be the hemoglobin bound oxygen, I'm going to take that. But mostly the hemoglobin bound oxygen is going to carry. That's why that is the important thing over there. Now, see over here. Whenever the graphs are going to come, I told you always and always do two things. What are the two things you need to do? First thing, don't get scared. Second thing, see the X and Y axis. Always do those two things. Okay. First thing first, let's see this. Over here, the partial pressure of oxygen is given. Same partial pressure of oxygen is given. But look at the y-axis. It is the saturation and the content over here. If they have written the oxygen ml per deciliter or per 100 ml or percentage, it's one and the same thing, right? So that means they're talking about content in the left-hand side diagram and the saturation on the right-hand side diagram. See over here, what will happen to the oxygen content in the anemia, especially which one? Anemic hypoxia. What will happen over here? See, this is the normal one and the answer is given over here, right? So why I'm saying so? Because this was the question which was asked in the INI CET 2023 May exam, and the option was given, the answer was there in the graph. I always tell you that the key is there in the graph. You just have to find it out. Okay, they just asked which type of hypoxia is shown by this you can say graph, right? And the answer was given. You can see that the one graph is showing 15 gram% of the hemoglobin, one is showing 7.5 gram. So it is nothing but the anemic hypoxia, right? So answer was given. But anyways, let's see. So what will happen? Let's say this is the normal level. I told you this is going to be the normal level around 19 ml and around 14 ml. That is going to be on the arterial and venous side. That means 5 ml is going to given or it is going to go towards the tissue. All right. But I told you if the lesser carriers are available, lesser will be the oxygen carrying capacity of the blood, which is going to decrease, right? So overall content on both the side, arterial side also and the venous side also, it is going to decrease. All right. So this is going to be the condition of anemic hypoxia. It cannot be any other than anemic hypoxia. If such graph comes, then your answer should be only and only anemic hypoxia. All right. Now, see over here, this is the saturation graph. The other graph is of saturation graph. See over here, the saturation, that means I'm talking in terms of one single hemoglobin. If I take one single hemoglobin, whatever hemoglobin is available in the anemic hypoxic patient, of course, the hemoglobin don't have any problem. So 4 molecules are going to be there in one hemoglobin. So 4 globin chains will be bound to the oxygen. So it is going to be 100 mmHg, right? So it is normal. It is going to be normal, right? So it is around 100 mmHg, which is going to be normal in this case also. Okay. Now, if I talk in terms of the saturation is going to be 100 and it is going to be around 95 to 98 mmHg partial pressure. Okay. Now, if I talk about the venous side, since the tissue require 5, you can say ml per 100 ml of blood. So, if it requires particular oxygen, it is going to extract, but overall content is lesser. Again, listen to me. Overall content is lesser, saturation is normal. So, it is going to extract more oxygen from whatever hemoglobin is available. So, if let's say only 2 molecules of oxygen was going from one hemoglobin, now the overall hemoglobin is lesser. So, the tissue is going to extract 3 molecules from each of the hemoglobin, or if say 4 molecules. What will happen to the venous saturation of hemoglobin or oxygenated hemoglobin? It is going to decrease, right? Because the tissue is extracting more oxygen from whatever hemoglobin is available. So this is also the graph of anemic hypoxia. The only change over here is we are looking at either content or we are looking at the saturation. All right. So please remember the venous side also I'm going to have a lesser saturation in case of saturation, also in case of content also. Only the change will be there in the arterial side. Okay. If it is content is low. If it is saturation, it is going to be normal in case of the arterial side. Okay. So that is the difference. If any such graph comes, they ask any type of hypoxia. It cannot be any other than the, you can say, anemic hypoxia. So please remember that. Okay. The last point, I want to end this class on a happy note. So last thing, one extra add-on point, if you write that, I promise you, the examiner is going to be very happy. Why? Because this is known as happy hypoxia and most of the student doesn't know about it. Okay. So happy hypoxia, what is it? We discovered that around the COVID-19 time, especially in the Indonesia, this was discovered that they have seen that many young patients, when they came to the hospital, they were absolutely fine. They were happy. They're living, they're walking, they're chatting, they're doing or giving answers, whatever the question the doctors are asking, right? But when accidentally, when they checked their oxygen level, because we were checking in the COVID-19, we were checking the oxygen levels via the pulse oximetry. They found out that their oxygen is pretty lesser. All right. So that means this is known as happy hypoxia. The patients are not showing the symptoms. They are not having something known as dyspnea. What is dyspnea? Dyspnea means difficulty in breathing. When there is low amount of partial pressure of oxygen, of course, what will happen? The person will start having hyperventilation. Eventually, the muscle will contract more and eventually the person will go in the fatigue and he's going to have a lot of problem in the respiration. So that is known as difficulty in breathing. The fancy terminology is dyspnea. The patient was not showing dyspnea. They were absolutely fine, but the body had lesser partial pressure of oxygen, right? So that is known as silent hypoxia or known as happy hypoxia. It is the generalized hypoxia as it is seen in everybody else, that does not coincide with the shortness of breath, which is known as dyspnea. Okay, so body doesn't show immediate symptoms. Yes, later on it is going to have the problems. Why? Because as soon as it gets severe, the body will not be able to generate the ATP. Utilize story though, generate bhi nahi kar paye, right? So what will happen? The oxygen levels are going to fall. And when they found out, the oxygen levels were below 90%, but the person can walk, talk normally, all right, causing increase in severity amongst younger patient. Understand? When they found out that their oxygen levels are 80% at that time, severe hypoxia, or 80, 70 mmHg pressure, at that time the patient had started showing the symptoms like headache, nausea, and even dyspnea, and unable to walk, all these things. All right. So what we need to do over there, just monitor the patient, use the pulse oximeter, closely observe other symptoms like discoloration of the lips. Of course, the patient will start showing the cyanosis, right? So lips, skin, mucosa, right? And profuse sweating without much of the physical work, right, may be a symptom. So please remember, this is known as happy hypoxia. You can write that in the applied aspect. All right. So if you have any questions, doubt, you can ask me right now. Right, I'm done with the explanation. If you have any doubt, please do ask. I'm there to solve that doubt. If not, then we can just say bye-bye, and I'll be putting a 2 to 3 questions on this topic. Let's see, will you be able to solve those questions or not? Okay. So that is all from my side. I hope you understood what do you mean by content, what do you mean by saturation, what do you mean by partial pressure, what do you mean by oxygen bound hemoglobin. All right. So if you understood this, everything is going to be perfectly fine, right? You will be able to solve all the doubts and all the questions. All right. So that is all from my side. I hope there are no questions. Keep calm and breathe smart. All right. So that is all. Bye-bye. Take care. Okay, if you have any doubts which you remember later on, which later on you got to know that yes, ma'am told something but I'm not able to solve that question, you can contact me on Physio by Pooja. That is my Instagram ID, or just in the group write Dr. Pooja Nigade on the Telegram group. I'll be available, all right, in the Cerebellum's group. So that is all. Bye bye guys. Good evening. Take care.